All right, Ninja Nerds, in this video we're going to talk about compliance. So first off, how would we define compliance? Well, we have a mathematical definition of compliance, and I'm just going to give you a kind of like a simple term of compliance. Let's write compliance right down here. So what is compliance? Compliance is defined as the change in volume. In this case, we're talking about the lungs or the chest wall. Right, so compliance could be for, again, it could be for the actual lungs, or it could be for the chest wall, and we'll talk about both of these. So compliance is equal to the change in volume of the lungs over the change in the pressure. Okay? But simply, when we talk about compliance, compliance is a measure of stretchability or distensibility. In other words, if I want to stretch something, it stretches very easily. You know, like a rubber band or something like that. Stretches very easily, okay? Something like that is very compliant. Our lungs are naturally very compliant, but at the same time, they have the opposite of that. They have just the right amount of elasticity. So in order for us to talk about compliance, we have to compare compliance to another term, which is referred to as elasticity. Because compliance is it's another way of explaining is it's the ease at which you stretch something. It's how easy it is to stretch it. Where elasticity is the resistance to the stretch. It wants to recoil. Assume the smallest size possible. So elasticity, and again, there is the elasticity of the same thing, the lungs, as well as the chest wall. But this situation is opposite. It's dependent upon the change in pressure over the change in volume. And we'll explain what we mean by these formulas here. Let's do that before we go into all of these examples in which compliance can actually vary in certain scenarios. So if we talk about compliance first, let's see how we can compare the situation with volume, okay, change in volume to compliance, and the change in pressure to compliance. All right, so first things first, how would we say that volume is affecting compliance? It's simple. They're directly proportional. So we can say from this formula that the change in volume is directly proportional to the compliance, whether it be the compliance of the lungs or whether it be the compliance of the chest wall. Whereas, if we increase pressure, what happens to the compliance? It decreases. So the change in pressure is inversely proportional to the compliance. In other words, if we increase the pressure, it decreases the compliance. If we decrease the pressure, it increases the compliance. And we'll talk about what this pressure is. Because technically, if I were to rewrite this pressure here, if we're talking about the lungs, actually we'll talk about it in a little bit. Because if it's in the lungs, it's the transpulmonary. If it's across the chest wall, it's transthoracic. We'll write that down now. Let's write that down here. So if it's for the lungs, it's transpulmonary. We'll actually go and show examples of this. But if it's the chest wall, it's the transthoracic pressure. If you remember TTP, we denoted it. Same thing for this. For the lungs, the change in pressure is the transpulmonary pressure, the TP, and the chest wall, which is going to be TTP. Okay, now elasticity. Look at the relationship here. Any increase in the pressure, any change in the pressure upon which it's increasing is directly proportional to the elasticity. So in other words, if you increase the change in the pressure, you increase the actual elasticity. Whereas, if you change the volume, if I try to stretch something, I'm increasing the volume. What does that do to the elasticity? It decreases it. So these are inversely proportional. So I just really wanted to make sure that we differentiate the term compliance from elasticity because they are not the same term. They're not of the same thing. They're exactly opposites. Okay, now what I want to do is, I want to talk about what is affecting compliance in the lungs. So what's actually maintaining this normal compliance within the lungs? And then what we'll do after that. So what's the first thing I want us to do? First thing I want us to do in this video is talk about what things are affecting compliance normally. So what affects compliance normally? That's the first thing I want to do. Okay? Then the second thing that I want to do is I want to go ahead and relate these changes in volumes and changes in pressures with real life examples to compliance. So then we're going to compare delta V, which is the change in volume, and then delta P, which is the change in pressure, to compliance. and then we'll throw in there some clinical correlations with that, okay? So let's go ahead and start that. So first thing, what is affecting compliance normally? Okay, there's three main things that are affecting compliance. I want you to remember these. So three main things affecting compliance. Here, look at this. Here, three main things affecting compliance. First thing is elasticity of the lungs. This is one thing that is actually affecting compliance, the elasticity of the lungs. Second thing that's affecting compliance is the surface tension. We've talked about this a couple times. It's that tension that's developed in the alveoli of the lungs, right? Between the air and the water interface. It's trying to shrink the alveoli. It's trying to make the alveoli collapse. And the third thing that's affecting compliance is the elasticity of the chest wall. Okay. So let's explain what each one of these things is actually trying to do. So let's first start off with the elasticity of the lungs. Now, our lungs they can stretch, but they naturally want to snap back. But there's just the right amount. So in our lungs, you know, there's different types of tissues within our lungs. But in general, our lungs are generally very compliant. They're very compliant. But they also have just the right amount of elasticity. So they're very compliant, but they have just the right amount of elasticity, just the right amount. So what do I mean by this? The lungs can actually expand with ease. Okay, they can expand with ease. We have to utilize some skeletal muscle to assist in that process, but they can easily expand. But they also want to recoil. Let's say, for example, though, that I change the elasticity. So right now, the compliance of the lung, so the compliance of the lung is pretty much equal to the elasticity. Okay, they're in just a nice interplay there, a nice interplay. Let's say that I change the situation up. Let's say I actually make the lung more elastic. How can I make the lung more elastic? Well, I prevent it from wanting to stretch. Okay, that's how I do it. I prevent it from wanting to stretch. How do we know that? Because we did the formula. We said that what? In the formula. In the formula, we said that if you actually decrease the volume, in other words, you just don't allow for the lung to stretch as much, it'll actually do what? If you decrease the volume, it'll increase the elasticity, right? Or vice versa. If you want to increase the elasticity, you actually do what? Decrease the volume. So it's not going to want to stretch. In this situation, let's say that the person unfortunately has what's called pulmonary fibrosis, right? So they have pulmonary fibrosis. In other words, let's say here is actually over here. Let's say over here, you have this person's lung, right? They have just the right amount of elastic tissue. But now, I'm going to do this in like this brownish color. This brownish color is to represent fibrous tissue. So let's say that if someone's getting older or they have certain type of situation, they're developing a lot of fibrous tissue. And a lot of fibrous tissue is developing all around the lungs. As this starts developing a lot of fibrous tissue, what's the whole point of this? Well, fibrous tissue is not distensible. It doesn't like to be stretched. So if you actually have a lot of fibrous tissue deposits here, instead of normal, healthy lung tissue, so a lot of scar tissue, fibrous tissue is really scar tissue. So let's say this is a lot of scar tissue, which is the pulmonary fibrosis that we said here. A lot of scar tissue formation, it's not distensible. So if it doesn't want to stretch, what happens to the compliance? The compliance decreases, but the elasticity increases, okay? So if there is pulmonary fibrosis, a lot of scar tissue formation, okay, that fibrous tissue accumulation, it's not going to want to stretch. So what happens to the elasticity? Now the elasticity goes up and the compliance decreases. So let's write that here. We'll do it with color coordinated, right? So in this situation, compliance is actually going to what? Decrease, and then what happens to the elasticity? The elasticity increases. And what's the whole overall effect on the lungs? The lungs will not want to expand or they'll want to recoil constantly. So they're going to have a hard time being able to be inflated. This is an example of some type of restrictive pulmonary disorder where they have a low forced vital capacity. Let's take the opposite. Now let's say that we actually make the lung super compliant. Okay, now we take the opposite. Let's say that I break down a lot of that elastic tissue there. So let's say that we use the example here of, there's a disease called emphysema. So there's a disease here called emphysema. And emphysema is a disease. You know, in the alveoli, they have a lot of this pink tissue here. A lot of these they're very, normal alveoli have a large surface area. Normal, healthy alveoli have a large surface area. So that's one really important thing about alveoli is they have a large surface area. But with emphysema, those neutrophils start releasing a loss of elastase enzymes, and the alpha-1 antitrypsin isn't preventing it. And what starts happening? They start breaking down a lot of that elastic tissue. As you start breaking down a lot of that elastic tissue, what's going to happen to the lungs? Well, now they're not going to have as much elasticity. If they don't have as much elasticity, then what does that mean? Well, if their elasticity is decreasing, what do we say elasticity? Okay, let's go back to the formula. Well, we said that this is inversely proportional. So if elasticity decreases, what happens to the volume? It increases. Well, I thought if volume increases, compliance increases. It does. You see how it's not that bad? If we use the formulas, they can help us to really understand this. So in this situation, and actually emphysema, a chronic obstructive pulmonary disorder, the lungs are very floppy. So they're not very compliant. So in other words, you can take a lot of air in. It's easy for these individuals to take a lot of air in, generally. But the problem is what does elasticity of the lungs allow for? Expiration, passively, right? So because of that, when the lungs collapse, they help to be able to push the air out passively without having to put a lot of work into it. But in these individuals, they're not very actually elastic. They're very compliant. And so their elasticity is very less. So they have very little elasticity, so the lungs aren't going to snap back as well. And so they're going to have a hard time being able to get air out. So they have a low forced expiratory volume. So in this situation, we take the opposite. So what happens to their compliance? Their compliance goes up, and their elasticity goes down. Not too bad. So now that we've done elasticity of the lungs, let's do the elasticity of the chest wall. Let's just stick with this concept here. Okay, and after we do surface tension, I'm going to talk about pressure too, how pressure affects these things. Okay, so let's do this one in purple. Let's do this one in purple. So let's say we talk about the chest wall. Okay, chest wall. Again, same thing. Chest wall is generally very compliant. And what do we say about the lungs? Lungs generally have an inward recoil, right? They want to snap. Again, we said it like this, right? If we showed the arrow, it always wants to snap in like this, whereas the chest wall wants to have a outward recoil, right? It likes to be stretched outwards. That's what helps to keep this intrapleural pressure nice and negative. Well, in this situation, there's a nice interplay between the chest wall elasticity, right, and the chest wall compliance. So it's like, we said again, compliance of the chest wall is just enough that there's not any type of situation where there's one overcoming the other. It's just the right amount in normal healthy individuals where there's this nice dynamic, and we need to make sure that we say this because it's not always perfect. There's this kind of pull on one side, but it's always trying to keep it in equilibrium. So there's a dynamic interplay between these two to maintain the natural compliance and elasticity. But again, let's understand this in pathological conditions or just in different types of physiological situations. Let's say that this person, their chest wall, let's say that they have ankylosing spondylitis. It's a situation, it's an inflammatory arthritis. And in that inflammatory arthritis, they have kind of like a hunched over posture, right? So in this situation, which is called ankylosing spondylitis, or, there's another one. It's called kyphosis. Kyphosis is when they have that hunched over posture too. Their chest cavity is kind of like bent over like that. So they have kyphosis. So an individual, we can even have what's called kyphosis, or even scoliosis too. And even scoliosis, if you guys remember scoliosis. So kyphosis, I like to remember like this. Let's say here's the K. Here's the guy's. Put the guy's head like this. Put his feet right here. And here's his arms like that. He's actually having a hunched over posture. So he has that hunched over posture. Whereas scoliosis, they have a abnormally S-shaped spine, right? And again, here's the guy, here's his arms, whatever. Just a little funny diagram there. So kyphosis, they have a hunched over posture. So does ankylosing spondylitis and scoliosis. You know what else can happen in these individuals? Let's say that there's another person, no abnormality. You just get older. When we get older, we get a little bit more decrepit. Our cartilage, within the actual ribs and stuff like that, it starts to get really, really ossified, and it doesn't want to allow for stretching. So if that happens, this can also affect the actual stretching desire of the chest wall. So in certain situations in which as we get older, like the ossifying, you ossify the actual cartilage around the ribs, cartilage of ribs. And so it doesn't allow for that expansion. Okay, so anyway, we got this one. Ankylosing spondylitis, kyphosis, scoliosis, or even ossification of the cartilage of the ribs. What would that do to the compliance? Okay, if you're in this hunched over position and you're stuck like this, I'm gonna have a hard time bringing air in. So imagine me trying to do that. It's hard doing it right here, but then if I hunch back over, into normal position, I can take a decent amount of air in. So because of that, these people are gonna have a really hard time bringing air in. So their compliance is gonna decrease because their chest wall is not very good at being able to have that nice distensibility. So because of that, the compliance of their chest wall decreases. Okay? So these people have a decreased compliance of the chest wall. And in the opposite of that, because of them maybe having some ossification of the cartilage or the ribs or these type of situations, they're stuck in that position. They have a hard time being able to go back to that normal position. They're kind of stuck in that position. So because of that, if you think about it, it's not necessarily that their elasticity is actually increasing. It's really more that their chest wall just doesn't have the ability to expand. We can say in a way that their elasticity is increasing, but we're not going to do that here because more of the situation here is that the compliance of their chest wall is actually decreasing. So it doesn't want to actually stretch out and expand to allow for the lungs to fill with air. And you can imagine if there was some type of situation in which the chest wall was very, very flexible, right? If the chest wall was very, very flexible for whatever reason, if the chest wall was very, very actually flexible and it can actually expand out a lot, then what does that mean? That means that the compliance goes up. And if the compliance of the chest wall goes up, what does that mean? That means we can actually inhale more air. So it's that simple, right? So not very, very confusing. Next one, let's do surface tension. So surface tension, and then we're going to talk about pressure. So we're going to go a little bit more into these formulas right after this. So now let's talk about surface tension. Let's do this one in this nice blue color here. Okay, so the next one is surface tension. First off, what is surface tension? We'll talk about this in more detail in another video, but surface tension is basically whenever you take like an alveoli, let's say here's an alveoli, and you have this liquid, you have this actual water layer. There's a nice little water layer here that's interacting with the air. Sometimes what can happen is there can be a lot of tension developed between the air and the water interface. And what this does is it tries to actually shrink. The whole purpose of it is it tries to shrink the alveoli. And when it tries to shrink the alveoli, it tries to collapse the alveoli. It wants to get to be as small as possible. Well, if you think about that, if alveoli are the basic functional unit and structural unit of our lungs are made up of many of these. So if all of these alveoli start shrinking, what's going to happen to the lungs? They're all going to want to start trying to be as small as possible. If they become very, very small, what is that going to do then? That's going to be a lot of resistance against me trying to bring air in. There's a situation that this can happen in infants when they don't produce enough of a protein-lipid complex called surfactant. We'll talk about it. It's called infant respiratory distress syndrome. And what happens is, because of that, there's so much surface tension that it takes so much effort, so much work to bring in as much air as possible to inflate the alveoli. So because of that, if you imagine if the surface tension is increasing excessively in some type of situation like we gave an example, infant respiratory distress syndrome, where they don't make a protein-lipid complex called surfactant, what would this do to the compliance? It would decrease the actual compliance. What would that mean for this individual? They would have a really, really hard time bringing air in. It would increase the workload of breathing. So what would it do? What would this decrease compliance do? This would decrease not decrease the workload, this would increase the workload of the breathing process. So this would increase the work of breathing. That's why these babies or infants that have this situation, you usually have to put them on a mechanical ventilator because they can't breathe on their own. They have a hard time being able to inflate the alveoli. And even when they expire, the alveoli collapse. And it takes so much effort to reinflate them. So it's a terrible situation. But let's take the normal situation. So let's say that this is the extreme. What if you produce a protein called surfactant? You know, there's a protein-lipid complex that our type 2 alveolar cells produce. And the whole purpose is that they try to decrease this surface tension. And when they try to decrease the surface tension, that tries to decrease the desire of this alveoli to collapse. And when it prevents this actual recoil, it allows for the alveoli to then, instead of wanting to recoil, to allow for it to expand. So if we decrease the surface tension, and how could we do that? How can we decrease the surface tension? We give, you have this person producing normal amounts of surfactant, which is this protein-lipid complex. And what that does is that decreases the surface tension. So if that's the case, then let's say I redraw this alveoli. And again, I put here, this is the liquid right here, and it's interacting with the air. So there's this air-water interface. And what's happening is that you're trying to be able to decrease the surface tension. So what's going to happen now? If you decrease the surface tension between the air-water interface, here's the air, here's the water, right? You're going to allow for this alveoli to more likely want to expand. And if the alveoli want to expand and not recoil, what does that mean for the lungs? Well, again, this is the basic structural and functional unit. So if this wants to expand, all of the lung would want to expand. And if the lungs wants to expand, what does that mean for compliance? That means that the compliance is increasing, right? And so compliance for this situation compliance should increase. And what does that mean for the workload? It decreases the actual work of breathing. Man, it's a beautiful thing. Okay. But now, these are the three main things that affects compliance, okay? These are the things I really want you to remember. But if you really want to be good at compliance, you really want to be able to remember other things that really is important, I want you to remember two other situations. That is neuromuscular problems. Okay? So I want you to remember this neuromuscular problem. And this is going to be the main thing. We'll just specifically talk about this one. One more thing that I want to talk about, neuromuscular problems. Let's say that you have a situation where the diaphragm is injured. If the diaphragm, by some terrible situation, is injured and it's damaged and it can't contract, will it be able to contribute to the inspiration process? No. If the diaphragm is damaged, will the lungs be able to expand? No. So what does that do to the compliance? It decreases compliance. Let's say by some situation you paralyze your external intercostal muscles. If you paralyze the external intercostal muscles, what does that mean for that? That means that they can't lift the ribs outward like the bucket handle movement. That means that they can't pull the sternum outward like this, like the pump handle movement. What does that mean for the actual expansion of the lungs? It decreases. So what does that mean for compliance? It decreases. But that's the muscles directly. You know, there's another terrible condition. Remember, this was the VRG, and it was sending down these axons into the actual anterior gray horn of the spinal cord. You know, there's a disease that damages some of these neurons right here that come out and supply these muscles. Okay, look. This condition, which can actually destroy these actual neurons right here, these anterior, specifically in the ventral gray horn of the spinal cord. They call it ALS. ALS, which stands for amyotropic lateral sclerosis, right? In that situation in which someone has ALS, it destroys these neurons. If these neurons are destroyed, will they be able to send action potentials out to the diaphragm? No. So the action potentials out to the diaphragm are decreased. Will the muscle be able to contract? No. If it can't contract, what will that do to the actual compliance? It'll decrease the compliance. Same thing here. If you damage these actual ventral gray horn, right, the somatic motor neurons there, the cell bodies, they're not going to be able to send muscles to send impulses to the external intercostals. If that's the case, these muscles can't contract and they can't elevate the ribs and pull the actual sternum out. And that would also decrease compliance. Last thing I want to talk about is, one more thing before we finish this right here. One more thing that can also affect compliance before we go in here and explain these pressures and volumes a little bit more is this situation here. Let's say that someone has mucus. So they don't actually have, like, let's say that we have a situation here where they have a lot of mucus building up here. If you have a lot of mucus building up inside of these actual bronchi or bronchioles or whatever, maybe due to chronic bronchitis or cystic fibrosis, whatever it might be, what happens to the air? Can the air get in? No. All this air is prevented from getting into the alveoli. If you can't get air into the alveoli, what happens to the alveoli? They become underventilated. If they're underventilated, will the alveoli be able to expand as well as the lungs be able to expand? No. So if there's a lot of mucus buildup, what could that do? A lot of mucus buildup could also decrease the compliance of the lungs. All right, so what if I poke a hole? What if I poke a hole through the chest wall and into the parietal pleura, and I open up the actual pleural cavity to the atmosphere? Let's say that I do that. Let's say that somehow I got stabbed, it went through the skin and went through the actual muscle tissue and through this connective tissue structures, and it penetrated and punctured a hole, and it opened up this space here. Look at this. All that's open. So now, what was the actual pressure in here? What was this pressure? Do you guys remember this pressure? In the pleural cavity, it was called the intrapleural pressure. The intrapleural pressure is normally closest to about -4 millimeter mercury. And then what did we say the intrapulmonary pressure was? The intrapulmonary pressure was approximately, during this process, right, it's about 0 millimeter mercury. And then we said that the pressure in the atmosphere was approximately about 760 millimeter mercury, right? Because again, these two, there's no change between this one and this one is actually a 4 millimeter mercury difference. So I could even rewrite this one as 760 mmg or 756 mmg. But nonetheless, look at this. Look what happens. The atmospheric pressure is 760. How could I write this one? Remember I said we could write it as 756. So let me write that as 756. 756 millimeters of mercury. Look at the pressure gradient difference. 760 millimeters of mercury to 756. What does the diffusion principle say? Things like to go from areas of high pressure to areas of low pressure. So where will the air start flowing? The air will start flowing very, very viciously and vigorously into the actual pleural cavity. As it starts accumulating within the pleural cavity, what starts happening? Air starts accumulating. As air starts accumulating into the pleural cavity, what is that called? What is that called whenever air accumulates in the pleural cavity? You know it's called pneumothorax? It's called a pneumothorax. What do you call it whenever there's some type of infection? There's actually the capillaries here. You have the pulmonary capillaries, and the pulmonary capillaries are actually supplying the alveoli. Let's say by some situation there's some type of infection or damage, and some of the blood from this actually leaks out here. What is that called? What is that situation called? That situation right there is called a hemothorax. Anyway, nonetheless, any type of situation in which air or blood or different types of fluid is actually accumulating inside of this actual pleural cavity, what do you think it's going to do to the intrapleural pressure? It's going to increase the intrapleural pressure. So as more air accumulates, the air is going to keep flowing in and flowing in and flowing into this actual pleural cavity until the intrapleural pressure equalizes with the atmospheric pressure. What is the atmospheric pressure? 760. So what will the intrapleural pressure become? The intrapleural pressure will eventually keep receiving air until it equals atmospheric pressure, which is 760 millimeter mercury. What is that in this terms? -4 will go up to 0 millimeter mercury, which is 760, right? Now look at this. When the intrapleural pressure, the pressure inside of this pleural cavity, equalizes with the actual intrapulmonary pressure, even by some chance it becomes even greater, like +1, it's going to start pushing on the actual lungs. And as it starts pushing and pushing and pushing and pushing on the lungs, creating this actual force, what is it going to try to do? It's going to try to collapse the lungs. What would that do to the compliance? It would decrease the compliance, right? So it's going to try to collapse the lung. What does that call whenever you collapse the lung? What is lung collapse called? Whether it be the pneumothorax or hemothorax or other different types of situations, any type of pleural effusion that's accumulating out there. This could introduce what's called atelectasis, right? So atelectasis. Okay? So now, if this is a lung collapse, right? What is the lung trying to do? It's trying to shrink. If it's trying to shrink, what does that mean for elasticity? It's trying to actually snap back, right? So in a way you can think about it, if it's trying to be very elastic. If it's trying to be very elastic, it wants to snap back and become very, very small. What does that do to the volume of the lung? Well, the volume of the lung will start decreasing. If the volume of the lung starts decreasing, what does that mean for compliance? If volume decreases, compliance decreases. It's not that bad, right? All right, so in this video we talked a lot about compliance and elasticity, and we basically focused on what? What affects compliance normally, right? We talked about elasticity of the lungs, elasticity of the chest wall, surface tension, neuromuscular problems. We compiled a whole bunch of different types of disorders or different types of physiological conditions that can affect it. And then we compared this whole change in volume, change in pressure to compliance along all of these examples, right? And then we even threw in there a little pathological condition called pneumothorax and hemothorax to compare it with atelectasis, all right? All right, engineers, I hope all of this stuff made sense. I hope you guys did enjoy it. If you did, please hit the like button, comment down in the comment section, and please subscribe. All right, engineers, as always, until next time.